Hi, everybody. My name is Dr. Jessica Chambers, and I am going to be reviewing your cardiac case study packet for this week. I will just be going through them from beginning to end, and hopefully, I will be able to answer the questions that you have and provide just some clarification. Um, if after we go over this packet, you still are confused or have questions, feel free to attend my office hours on Wednesday from 8 a.m. to noon. Also, you can feel free to reach out and set up a time to meet with me. I'll provide you with my contact information at the end. I do want to encourage you, if you have not gone through the case study packet and read the material and watched the Khan Academy videos, I really encourage you to stop this video and go back and do that first. I think it will really help your understanding, and I know students in the past have gotten a lot more out of this lecture if they did the work before watching the answer video. So just a suggestion. I will just also say that this is the first time I've actually recorded this without having students. Typically, this is a very engaging process when we're going through all of these different defects and kind of talking through it. So feel free to pause it and write down any questions you have. And again, I'll be happy to answer them. So just to start with our first case study number 1, we have AJ, who is a 4-week-old, seen in the clinic for a well check, and he has a loud systolic machine-like murmur that was not previously heard. He is tachypnic, and his mother reports he has not been breastfeeding well over the past 2 days. The nurse also reports auscultating crackles throughout his lungs, and the provider suspects a persistent patent ductus arteriosus, or a PDA. What would the nurse expect the provider to order to confirm the diagnosis? So, um, first of all, just looking at this picture here, and this is probably something that will be answered more in questions 2 and 3. But in order to help you understand question number 1, so what is a patent ductus arteriosus? So in utero, we all have this structure. Just looking at the heart, this is a drawing that I did not do but found online. We have our different structures here. So this would be our pulmonary artery. So I'll just put a P and an A so we know what that is. And then we have this structure here, which is our aorta or aortic arch. So I'll just put AA for aortic arch. And the ductus arteriosus is a structure that is joined between these two major arteries. It's right here where the arrow points. So this is an anatomic structure. So this question is asking, what would the nurse expect the provider to order to confirm the diagnosis? So A is a chest radiograph. So a chest radiograph or a chest x-ray can give us some information about the cardiac structure, such as the size, the shape, whether or not it's shifted, what do the lungs look like, do we have pulmonary overcirculation because of something that has to do with the heart. But it wouldn't necessarily tell us that, well, it definitely would not tell us that this is open or that this is present. So A is incorrect. B is a complete blood count or CBC. That is a lab that tells us the counts of different blood cells that we have. So that also would not tell us that we have a patent ductus arteriosus. So B is also incorrect. C is an echocardiogram. So that is an ultrasound of the heart, and that would show you the different anatomical structures. So C is actually the correct answer for number 1. And then D is an electrocardiogram or an ECG, also known as an EKG. So that tells you about the electrical function of the heart. So D would be incorrect. So again, for number 1, the answer is C. For question number 2, describe the location and the function of the ductus arteriosus in utero. So the location we talked about, the ductus is an opening between the two major vessels of the heart. So the pulmonary artery here, and then your aorta here or aortic arch. So it's a connection between those two. So the function of this in utero is for a baby or fetus who's growing inside a mom, the baby is receiving nutrients and oxygen from the mother via the placenta. So babies do not use their lungs for oxygenation. Now, babies do need their lungs to grow and develop, so they do need some, blood flow in order for that to happen, but they're not using their lungs to actually oxygenate their body. So what this does is as blood is flowing throughout the baby's system, a tiny bit trickle of that blood is going into the pulmonary vasculature in order to help the lungs grow and develop, but the majority of the blood is just continuing systemically through the aorta. Hopefully that makes sense. And then our next question is, how and when does the ductus arteriosus usually close? So that is somewhat of I don't want to say a tricky question, but it's a kind of a two-part question. So in utero, we have our systemic pressure and our pulmonary pressure. When babies are not born yet, their systemic pressure is low, and that's how the baby is able to successfully get blood flow, which carries oxygen and nutrients from the mother via the placenta. If their systemic pressure was high, then obviously it would not allow as much of that flow from the mom. So you have to have a low systemic pressure. But babies have a high pulmonary pressure. And that's because, again, they don't use their oxygen or I'm sorry, they don't use oxygen. They do use oxygen. That was not what I meant to say. They don't use their lungs to oxygenate their body. So when blood is trying to go into the pulmonary vasculature, there's high levels of resistance here or high pressure. So blood generally will only minimally go into that pulmonary vasculature and will stay systemic, as we previously talked about. So how and when does it close? So when babies are born, those pressures are supposed to shift. So your systemic pressure should rise, your pulmonary pressure should drop, and that allows more blood to flow into the pulmonary vasculature, and obviously for you to be able to use your lungs and oxygenate your blood to carry it to the rest of your body. So your systemic pressure should be higher, pulmonary pressure should be lower. If they did an echocardiogram of your heart and they looked at your pulmonary pressures, they should be lower than what your systemic blood pressure is reading. That would be normal. So how does it close? So things that, in order to understand how it closes, we have to understand what keeps it open. So low levels of oxygen would keep it open, because we know that when you look at low levels of oxygen versus high levels of oxygen, arteries are more dilated when you have lower levels of oxygen. And when you expose arteries to high levels of oxygen, they constrict. Since this is an opening between two arteries, then we know that if we have more oxygen, then this whole, structure here should start to constrict. But the main thing that keeps this open is prostaglandins, and prostaglandins come from the mom via the placenta, and that allows this structure to stay open so that, we make sure we are doing the right thing for the baby when the baby's growing. So for anyone who's ever had a baby or has children, some of the prenatal education is, make sure you're not taking NSAIDs, because we know that NSAIDs inhibit prostaglandin, and that could cause this ductus arteriosus to close prematurely, which can lead to the baby's death in utero. So how and when does it close? Going back to the actual question. So when baby's born, baby cries, baby screams, clears their lungs of all the amniotic fluid, oxygen saturations rise. So at birth, babies have oxygen saturations typically in the 55 to 65 range, and every minute old that the baby is, it rises by about 5 to 10%. So oxygenation is improving. And then also we have obviously that shift in pressures again that we talked about. So the pulmonary pressures drop, the systemic pressures rise. It kind of forces this to close. And then the other thing is we cut the umbilical cord. So we don't have that infusion of prostaglandin from mom via the placenta. So that starts to encourage that PDA to close. Now, Remember how I said there were kind of two parts to this question. So the first thing is, or the first type of closure is called functional closure. So that means that this is very, very, very constricted to where you have very minimal to no flow through this opening. But if you still needed it for some reason, it could still be opened. So it's not a permanent closure, but it's called a functional closure. And that happens typically within about, I would say, 24 to 48 hours, depending on what source you look at. It can happen as early as a couple hours of life to about 48 hours of life. And then you have something called anatomic closure, which means that the closure of this structure is permanent. It forms a ligament called the ligamentum arteriosum. And that is where it's a permanent closure. There is no intervention that you can do to force that open again. And that typically happens between 14 to 21 days of life. So our next question is, what are some of the initial interventions and or treatments used to attempt non-surgical closure of a PDA? So just going back for a second. So looking at our case study, this is a 4-week-old infant. So it's not knowing what we know about how and when a PDA should close. We know that this patient's PDA is open longer than it should be. So just to kind of make sure we're restating that. And then again, what are some of the initial interventions and or treatments used to attempt non-surgical closure of a PDA? So since we know that what keeps a PDA open is prostaglandins, then something we can try in order to close a PDA would be to inhibit prostaglandin. So remember how we talked about in pregnant women, we have them not use NSAIDs because it can inhibit prostaglandins and have this close prematurely. So you can actually give NSAIDs to the baby in order to encourage the structure to close. And some of the more common NSAIDs that we use are ibuprofen, acetaminophen, and indomethacin. What the literature tells us is that for acetaminophen, the most effective route is IV. So typically, if this is an otherwise healthy baby who, we want it to close for whatever reason, we won't typically we won't use IV Tylenol at home. So that would have to be someone who's inpatient. Indomethacin and ibuprofen are more effective by the oral route. So those are the more common ones that you would see being used. Other interventions or treatments that you can use are fluid restriction. So if we think about our blood volume, if we have a really high blood volume, then we typically will have more pressure, and more pressure through these structures will cause turbulence and flow and will force this to stay open because, of course, you have a higher blood volume. If you restrict fluids, then you wouldn't have as much pressure, so it may encourage this structure to start closing. And then other things you can use, of course, are diuretics, not something that's very commonly used, but if a baby does have a lot of extra flow to their lungs, because of course, a 4-week-old who is getting a lot of blood shunted from the aorta into the pulmonary vasculature is going to have a lot of excess fluid or pulmonary edema. So diuretics may be helpful. But the big things I want you to remember are fluid restriction, NSAIDs, so acetaminophen, ibuprofen, indomethacin. Those are probably the most common things that we will use as an initial attempt to close the PDA. And question number 5, AJ's mother asks, if cardiopulmonary bypass is needed during surgery to close the PDA, how should the nurse respond? So bypass is for surgeries that are intracardiac, typically. So this structure, the PDA, is extracardiac, so it's outside the heart. So we don't need to put a patient on bypass in order to perform this surgery. So the nurse should say no, that your baby will not require going on bypass because this defect or opening is outside of the actual heart. It's on or between the vessels. So we don't need to do that. And then our last question for this case study, number 6, under what circumstances would the healthcare team want the ductus arteriosus to remain open? So if you have a baby who has another structural defect, so some type of um, cardiac defect, obviously there are many that we'll go over in these case studies and it will make more sense to you later. Sometimes you need this opening in order for blood to be able to flow to the lungs. If things are connected wrong and there's an inability for the baby to oxygenate because blood cannot get to their lungs, then the only way for that to happen would be to have this structure stay open. So that would be your answer for number 6. Moving on to case study number 2, I don't have a drawing for that, so I'm just going to go through that and give you the answers. So Ryan is an 8-year-old who was brought to the school nurse by his teacher. He looks pale and walks unsteadily into the office. He complains of dizziness and states, "My head hurts and it's beating so fast." I'm sorry, "My heart hurts and it's beating so fast." What first actions should the nurse perform? So if you have a patient who is unsteady and pale and is saying that their chest hurts, obviously you would want them to sit or lie down. You would want to, you know, do a physical assessment, take vital signs, really do a thorough assessment on the patient. And maybe at that point, you're even calling for some assistance because the patient looks so unstable. So number 2, while completing a physical assessment, the nurse finds that the patient is diaphoretic, has cool extremities, a weak and rapid peripheral pulse, and 4 to 5 second capillary refill. His heart rate is too rapid to count, but appears to be over 200 beats per minute. The nurse suspects supraventricular tachycardia or SVT and calls 911 to report her findings. The nurse also calls Ryan's father, instructing him to meet Ryan at the hospital. While waiting for the ambulance to arrive, what are some non-pharmacologic interventions for SVT that the school nurse can attempt? So some non-pharmacologic interventions would be things that would help to slow your heart rate. So vagal maneuvers would be the answer for this. And some of those vagal maneuvers could include things like having the child hold their breath, bear down, so the Valsalva, taking a bag of ice and literally covering the child's face with it. That encourages the diving reflex, so that should slow your heart down. Or having the child immerse their face in ice cold water. Coughing, sometimes having them blow into a straw. So any of those things would help or encourage the heart rate to slow down. Again, those may or may not work. It just depends on it varies by situation. I've definitely taken care of babies and children who, within a few seconds of initiating these maneuvers, their heart rate converts back to sinus rhythm. And then I've had many situations where non-pharmacologic measures don't work. But typically, you would start with a non-pharmacologic measure before looking to other interventions. For question number 3, it says, what medication might be used by emergency medical services upon their arrival or at the emergency room if non-pharmacologic interventions fail? So the correct answer would be A, adenosine. B, and I'll come back to why that's correct, but B, amiodarone is wrong. That would be for things that are typically ventricular related. So like VFib, VTAC, we would not use that for supraventricular tachycardia. Atropine would make your heart beat faster, so not make sure you get the right medication. That's not what we would use to slow down a person's heart rate. And then, of course, D, any of the above are appropriate. That would be wrong. So the correct answer is A, adenosine. and that medication should help convert you into sinus rhythm by very, very briefly stopping your heart and, allowing it to convert. So, how is this medication administered? That is number four, and that is a rapid IV push. So, these are the medications where typically, you're connecting a stopcock and you have your medication connected to one port and a flush connected to another. And you are either by yourself preparing to, we like to call it slam the medication. So, push the adenosine as fast as you can and follow it with a flush, and the reason why adenosine is given in that manner is that the half life of the medication is very, very short. So if you give it slow, it will not be effective. So you want to do it rapid IV push. That's the answer for number four. For number five, what intervention may be necessary if SVT persists despite pharmacologic measures? So I've seen this less frequently, but I've still certainly seen it. They We would typically call Peds cardiology to come in, and we would attempt a cardioversion. And then if that does not work, then you could also proceed. If a child, of course, you can cardiovert them back into normal sinus rhythm. Um, but if they're having these recurrent, persistent episodes despite, medication and different interventions, then they could proceed to need an ablation. Um, I don't remember where I was going with that, but the main typical thing that you would see in the hospital would be a cardioversion. And so for number six, if this intervention is necessary, what should the nurse advocate for? So especially if you are taking care of nonverbal children or, little babies, very, very young toddlers, I have seen this a number of times where they put the pads on the baby's chest and it's a paced cardioversion and they shock and then the baby cries out. It is an uncomfortable, painful procedure. So, as the nurse, please be patient centered and advocate for your patient to get some pain medication. Our next case study is number three. Number one, we have Jennifer, a 3-year-old from Bethel, who was born with a large VSD along with severe mitral regurg. She has had a long, complicated course with multiple hospitalizations. Jennifer and her mother have been to Anchorage and Seattle for multiple tests and procedures. Today, she presents to the clinic with concerns for severe congestive heart failure or CHF. The plan was for Jennifer to gain more weight before her surgical repair. However, waiting may no longer be an option. What signs and symptoms of CHF would the nurse expect to find? So, some of the common signs and symptoms would include shortness of breath, sweating or diaphoresis, tachycardia, fatigue, and that's usually evident or exhibited by trouble eating, getting very, very tired while trying to feed, and issues with gaining weight, and then of course tachycardia because you have a heart that is working very, very hard to have effective cardiac output. Other things, I'm just trying to think. Other things you might see are an enlarged liver. um, I can't think of any other ones right now. So I think I've told you some of the main ones that you're looking at. Most commonly in kids this age, the big things are shortness of breath, often rapid breathing, labored breathing, tachycardia, and then difficulty with feeding and growing, of course. For number two, what are the main treatment goals to improve cardiac output in CHF? So the big things are, of course, you want to make sure that you're not fluid overloading the patient, that you are improving um, their ability to grow and not, you know, obviously have difficulty with perfusing their organs and all of those things. So, your main treatment goal is to help your heart pump as effectively as possible. For number three, what is the most common medication that Jennifer may be prescribed to help manage CHF and why? So, the most common medication is digoxin, and that is because digoxin helps to improve cardiac contractility, which will therefore improve cardiac output. So, it just helps the heart be a more effective pump. Number four, what should the nurse teach Jennifer's mother about the signs of toxicity associated with this medication? So I know that all of you know digoxin and know what the signs and symptoms of toxicity are, but I encourage you to think about it from the standpoint of a child who is nonverbal or very minimally verbal. So that, that yellow halo um, thing that we hear about that adults will tell us, or older children will tell us, you're not going to hear that probably from a 3-year old. So the most common things that you will see are GI symptoms, so nausea, vomiting, diarrhea. So if you have a parent who is calling in and telling you, hey, I think so and so is sick. She's been vomiting for the past 2 days, but doesn't have a fever, doesn't have any other symptoms. It's your responsibility as the nurse to know what this patient's medical history includes and what medications she is on, because that could be a sign that that child is experiencing signs of toxicity. The next question is number five. What additional medications might Jennifer be prescribed to treat CHF? And the answer to that is diuretics. So, because your heart is an ineffective pump, or this child's heart is an ineffective pump, we will likely have some degree of pulmonary overcirculation. So, with CHF, that's why we have a child who's having difficulty breathing. They have a lot of backflow into their pulmonary vasculature and causing, edema within their lungs. So, if you give them a diuretic, that will help clear that and help them be able to breathe more effectively. So that is the answer to number five, diuretics. So moving on to case study number four. And actually, I am just going to pause my recording briefly so that I can pull up a different drawing. Okay, so for case study number four, question one, the nurse attends a cesarean section for a term infant. The infant is born vigorous and breathing well, but has persistent cyanosis. The nurse administers blow by oxygen via bag mask and places a pulse oximeter on the infant's right wrist or right hand. The infant's oxygen saturation remains in the range of 78 to 82% despite administering 100% supplemental oxygen. The infant is breathing 40 breaths per minute and is not in any respiratory distress, but the oxygen saturations remain the same. The provider is immediately called to evaluate the infant. An emergent echocardiogram is ordered and shows transposition of the great arteries, or TGA. The father asks, "What does this all mean?" How does the nurse explain the cardiac defect to the father, specifically the consequences pertaining to this infant's circulation? So, let's just talk about what the normal versus the transposed arteries look like. So on the left, you'll see here there's a normal heart. We have our um, atria and our ventricles. We have our pulmonary artery coming off the right side, and we have our aorta coming off the left side, and all is good and well. This is appropriate. If we had a PDA, we would have that right here. Just gonna draw. Okay. And if we look at this picture here on the right, we have our aorta, which, just keep in mind in this picture, is blue, connected to the right side. We have our pulmonary artery connected to our left side. And if we had a PDA, it would be right here. Hopefully those are nice and dark to where you can see them. So we have a baby who is cyanotic, but they are vigorous. So active, crying, breathing normally. If we look at the rate, 40 breaths per minute is normal, is not in any respiratory distress. So we don't see grunting, we don't see nasal flaring, we don't see retracting or use of the baby's accessory muscles to breathe. Basically, this is a normal appearing baby, except the baby is blue. And even when the nurse gives the baby 100% oxygen, the baby is still blue. So that's clearly not normal. When they do the echocardiogram, they see that these two vessels here are switched. So what does that all mean when we're explaining this to the parent? So you can say something along the lines of the two major arteries that connect to your heart and provide circulation to either your body or to the pulmonary or the lungs. Lungs is probably a word that most parents would know. Those vessels are connected backwards. So you have, instead of your vessel that carries blood to your body being connected to the chamber of the heart that has oxygenated blood, it's actually connected to the chamber of the heart that carries deoxygenated blood, or blood that has no oxygen in it. And the vessel that is supposed to carry deoxygenated blood to your lungs to pick up oxygen is actually connected to I think I'm confusing myself, is actually connected to the other chamber with blood that is already supposed to be oxygenated. So they are flipped backwards. This is what happens when I try to say things in layman's terms when I'm trying to lecture. Sorry. So pretend like these are electrical plugs. I'm just going to draw what that might look like. Plugs. So imagine that you pull these both out of their sockets and you connect them backwards. So that's essentially what has happened here. You have a baby who's born with their major vessels connected wrong. So you might ask yourself, how is it that this baby is alive if they are not able to pick up and drop off oxygenated and deoxygenated blood where it needs to go? So remember that nice structure that we talked about called the PDA? So the reason that this baby is blue or cyanotic is because you have complete mixing of the blood at this level. So instead of this being red versus blue, when this PDA is here, it's all purple. That's why when you give the baby 100% oxygen and their saturations stay relatively the same, it's because there is no way for the blood to become more oxygenated. It's all mixed at the level of the PDA. Some babies are born with other defects they're called septal defects, so maybe in the atria or maybe in the ventricle. Some babies are not, it just depends. But again, of course, if this baby had a PDA and also an ASD or an atrial septal defect, it would be the same scenario. You'd have all kinds of mixing going on here. So a good way to help you understand this concept is you basically have two completely separate circuits that are running. You have your pulmonary circuit over here, and you have your systemic circuit over here. I'm sorry, actually it's backwards. You have your pulmonary circuit over here that's nice and oxygenated. You have your systemic circuit over here that's nice and deoxygenated. And then you are lucky because you have this opening here or an opening here or both that allows you to mix blood and allows the baby to stay alive until further intervention can be performed. But moving to question number 2, what must remain open until surgery is performed and why? So the answer to that question is the ductus arteriosus, or the PDA. Imagine that this baby does not have, hopefully I'm not going to erase this picture. Okay. Imagine that this baby does not have that atrial septal defect. The only opening is the PDA. What would happen to this baby if this PDA closed? Basically, you would then have absolutely no oxygen to the body, and you would have only oxygen in the pulmonary circulation. So you would need to do everything that you can to keep this open. So for number 3, what medication will be used to keep this open? So we know that in order to close the PDA, we would use NSAIDs such as acetaminophen, ibuprofen, or um, indomethacin, because those are prostaglandin inhibitors. So in order to keep the PDA open, you could give prostaglandin, and that is given through a continuous drip. It comes in a little vial, and you mix it with some D5, and then you would infuse it continuously. And the reason for a continuous infusion is that prostaglandin has a short half-life. So you would need it to keep infusing, otherwise you would have problems. And that should help keep this PDA open until the baby can get to a place where they can intervene. And we'll talk about what that looks like here in a couple questions. For number 4, what are the most common side effects associated with this medication? There are 2 pretty common ones. The first one is hyperthermia. So you might see a fever in this child. Think back to patho and the role of prostaglandins in your body temperature and all of that when you have a fever. And then the second one is apnea. So keep that in mind as we go through these questions. We might have to talk about that again. We will be talking about that one again. Question number 5, what are the 2 surgical interventions that are typically performed and how are they accomplished? So the first intervention, this opening here is not very reliable, first of all, and sometimes even on high doses of prostaglandin, you get to a point where it's very difficult to keep this open. So the first surgical intervention is called a balloon atrial septostomy. So they essentially would put in a balloon to create an opening between the atria. So we're going to pretend this is a balloon. So we're going to make a big old hole here. And that will help blood to mix until the baby can have a more permanent correction. And then the other surgical intervention, which is the actual correction, and just keep in mind, you know, cardiothoracic surgeons all do different things. There are different procedures that can be done. This is just the most common one for babies here in our state. When I transport babies south, this is the one that they do the most. So that's just the one I'm going to give you as an example. And it's also the easiest one to remember. So once the baby is stable, then they will put the baby on bypass and do a procedure where they do the great arterial switch. So they will unplug these vessels. So unplug the pulmonary artery, unplug the aorta from the wrong connections, and then connect them properly. So put the aorta back to the left ventricle and then pull the pulmonary artery back to the right ventricle. And then they will patch up this hole that they made because they should not need that any longer. So, number 6, the nurse is preparing the infant for transport. What orders would the nurse expect to find? So, let's think about what are all of the things that this baby will need in order to stay alive until they can get to a center that can do a procedure that will save this baby's life. So, what I can tell you is that none of these procedures are performed here in Alaska. So, uh, from our NICU, I work at the Providence NICU as a nurse practitioner, and I also fly throughout the state and pick up babies with, very different illnesses, but commonly we will pick up babies who have cardiac defects and stabilize them and then bring them down to the lower 48 for surgery. So thinking about a 3+ hour plane ride at altitude where babies and even us have lower oxygen saturations than we should, what are all of the things that we need to do to facilitate a safe flight? So Number one, we talked about we have to keep this PDA open. So prostaglandin. So we know that prostaglandin is given through a continuous drip and it's given IV. So as the nurse, it would be prudent to think, well, if I need to make sure that this baby is reliably getting a continuous drip through for the entire transport, you would want at least 2 intravenous lines. So probably two, one running IV or one running central line and at least one other point of access. So a HEP lock or saline lock. Other things, if you have a baby with a defect such as this and low oxygen saturations, this baby is probably not getting any type of breast milk or formula because we're not providing adequate perfusion to the intestines. So you don't want to feed a gut that is not getting adequate blood flow. You can cause a lot of problems that way. So this baby is likely NPO and has some IV fluids ordered. Obviously for a baby, we know that babies need glucose. Glucose is very important to the brain. So your IV fluids should have some type of dextrose in them. Other things, knowing the side effects of prostaglandin, the primary one is apnea. We would likely not want to put a breathing tube or intubate this baby in the plane. I've done it before. It's difficult. It's a small space. So likely this baby will be intubated before transport. So those are just some of the things that you as the nurse may expect to find ordered before the baby is leaving the facility. And something to know, often these babies are very, very sick and you need to act rather quickly in order to prepare this baby to leave and leave safely. So again, I'm going to pause this presentation and then pull up another set of pictures for you for our next case study. Okay, so moving on to case study number 5, we have question 1. The nurse attends a vaginal delivery for a term infant. The infant is born vigorous and breathing well, pinks up rapidly. The infant has a normal hospital course and is discharged home with his parents at 48 hours of life. At 8 days old, the infant presents to the emergency room because he is cold and not breastfeeding well. Assessment findings include bounding pulses in the upper extremities, absent pulses in the lower extremities. The provider examines the infant and suspects coarctation of the aorta, which is confirmed by echocardiogram. The mother asks, what does this all mean? How does the nurse explain this cardiac defect to the mother, specifically the consequences pertaining to the infant circulation? So if we look at this diagram of the heart on the left side of the screen, this is a normal heart. We have the aorta coming off nice and juicy from the left ventricle, pumping nice oxygenated blood to the body. If we look at this picture on the right, we have the aorta connected to the left ventricle appropriately. And it is juicy, juicy, juicy coming off, perfusing the body. And then it hits this point of resistance here. This is the coarcted segment. Basically, it's like a narrowed area of the aorta. Sometimes it can be very mild and sometimes it can be very severe. It just depends on the defect itself. And again, if we were to have a PDA, it would be between the pulmonary artery and the aorta here. So I'm just going to draw that so that we remember it's there. Okay. So what do you think this all means? So let's pretend we have this baby. So we're going to draw a head. Okay, this is a neck, of course. The body, not to scale. Obviously, the heart would not be that big. Got some arms. I'm not an artist. I apologize. Got some arms there and some legs or feet, whatever you want to call them, lower extremities. Okay. So we have blood that pumps from the left ventricle, pumps out. What do you think happens when it hits this point of resistance? I'll tell you. It's going to start backflowing, backflowing, backflowing. So it's going to go up here. This is what perfuses your arms. This black stuff is blood. This is what perfuses your brain, perfuses your arms. And then you might get a trickle of blood in the descending aorta down here. Okay. So when this mom is asking you what's going on, looking back at your assessment findings, so what are your pulses up here like? So we know from the case study they're bounding. So 4 plus, so super strong pulses. What about blood pressure? Your blood pressure here is going to be normal, normal, or high. You have your heart meeting this, pumping, meeting this point of resistance, and then backflowing. Well, what about in your lower extremities, in the lower part of your body that's below the heart? So you would have absent pulses maybe, or 1 plus pulses, very weak. Blood pressures would be low. So there would be a significant difference from your upper extremities and your lower extremities. And I actually answered number 2. What differences would the nurse expect to see in blood pressure? So you would likely be doing something called a 4-point blood pressure. You'd be taking blood pressures in all of the extremities. So your upper extremities might be something like, maybe it's like 80 over 30. And you have like a mean arterial pressure of 50. And then in your lower extremities, it might be, oops, I don't know what that is. 60 over 20 with a mean of 35. So if you look at the differences in blood pressure, that's a pretty significant difference. Anytime you have a 10-point difference in your systolic or in your mean, that's a sign that there's a problem. So those are the differences that you'd expect to see. So something to remember again, I'm just going to repeat it for emphasis. So pulses in your upper extremities, upper part of your body, bounding, strong pulses. Blood pressure, normal or high. This is for your upper extremities. In your lower extremities, you might have absent pulses or very, very weak pulses, and your blood pressure is low. So I don't know if you have learned about blood pressures for neonates. So your mean pressure that you're looking at should at minimum be the baby's gestational age. So if this is a term baby born at 40 weeks, this mean should be at least 40. Okay, sorry, I'm going back and forth between this and my packet. So for number 3, what must remain open until surgery is performed and why? So remember how we talked about our ductus arteriosus. So we would want that to remain open so that blood can shunt between the aorta and the pulmonary artery in order to get oxygen, nice and picked up to be able to deliver it to the rest of your body. Because remember, if you have this narrowing here and blood is only trickling down to the rest of your body, what do you think the return is like? You're not going to be getting a whole lot of blood back to your heart to be able to go out into your lungs and pick up oxygen. So you want there to be that that shunting of blood in order for the blood to become oxygenated. And how would this be accomplished? So it's the same as the previous case study. We would use prostaglandin as a continuous drip through an IV in order to keep that PDA nice and open. And if we look back at the case study, this baby was born fine, went home at 48 hours, came back into the hospital at 8 days old, not doing well. So, why do you think that is? Thinking about that for a minute. So, when the baby was born, likely the PDA was open. Also, if you think about what happens when the heart is really working hard to pump blood and you're getting a lot of backflow, the heart is going to keep working harder and harder and harder. So over time, this baby is probably developing some degree of heart failure because the heart is working so hard to get blood out to the body and it's meeting this resistance that it's having to work extra, extra hard to try to pump blood to where it needs to go. And so at first, after birth, this baby was doing just fine because one, you had this PDA, and two, you had this heart that was functioning just fine. But then over time, the heart has, been overworked, has had to work extra hard again to get blood to pump to the body and to get blood to be able to oxygenate. And then it's also working against this resistance. So that's why now you have this 8-day-old who probably has a smaller or absent PDA, functionally closed PDA, and is not feeding well and is having symptoms that are similar to heart failure. So it's very different when you compare the coarctation patient to the patient who had the transposition. So in a transposition, you don't have this pulmonary overcirculation where a lot of extra blood is going to your lungs. Because remember, the other thing with the PDA is likely there's a lot of extra blood that's going into the lungs. It's just you don't have this great return. With the transposition, you have these two separate circuits and you have this shunting of blood, but it's you're not having any extra blood going to your lungs. Hopefully that makes sense to you. Again, if any of this is confusing, I know this is a lot of material. Please come to my office hours. If those hours don't work for you, schedule a time to meet with me and I will be happy to explain further. Number 4, what surgical interventions will take place? So let me just erase some of this. Okay, sorry about that. I had to erase all of the stuff I drew on that last one. Okay, so what surgical interventions will take place? So if you look at this coarcted or narrowed segment, what they will do is they will go in and place either a stent here to open that up, or they will cut above, oops, and below that narrowed portion. And then they'll cut all that out and sew these pieces together. So then it'll be nice and connected properly here. And all that will be gone. Sometimes you will have a patient who has the coarctation that looks like this. So that's a little bit more troublesome because then they have to cut quite a bit out in order to get these two pieces connected properly. So it really depends on the baby and how significant the defect is. If the defect is very mild, the baby can certainly live to be, a child, young adult, and not have any issues. But it's when you have these very, very narrowed areas that it becomes a problem. And I think the next one is that itelicized question. In children with severe congenital heart disease, what other findings may be present? How would these findings be managed? And what dictates whether interventions are performed? We'll answer this as a class. So what I want you to think about is, what do you think happens in scenarios where you have this prolonged um, amount of deoxygenated blood circulating through your body? So you're going to likely go into metabolic acidosis because you're not getting enough perfusion to those organs, and that can cause a number of issues. And at the end of all of the cardiac case studies, I'm going to share a real life presentation with you of a patient that I took care of, and so that you can kind of put all the pieces together and see what I'm talking about with all these crazy pictures that are terrible drawings on my part. Um, Basically, when you have a child with severe metabolic acidosis, that can impact when they can have surgery, because you obviously don't want to um, overstress a child who's already in this horrible acidotic state and their organs aren't functioning properly. You may have to give bicarb, you may have to intubate the patient and help them kind of manage that by, you know, either messing with their, if you paralyze a baby and put them on the ventilator, you can manipulate their carbon dioxide levels. So, just depending on how sick the baby is, how quickly it was picked up that this was a cardiac problem, that will all affect how the baby is managed and what interventions are needed. Okay, I'm going to pause this again so that I can pull up another picture for our next case study. Okay, so moving on to our next case study, we have, and let me just tell you the number. Case study number 6, question 1. Jack is a 3-week-old infant who presents to the emergency room in respiratory distress. He's cyanotic and limp, eventually becomes apneic. He is intubated and placed on a ventilator. After performing a physical exam, the provider suspects a congenital heart defect and orders an echocardiogram, which confirms a diagnosis of tetralogy of Fallot. Jack's father asks the nurse, "What does this all mean?" The nurse explains there are 4 defects associated with this condition, which include the following. So we have, I so wish we had some kind of interaction, because I feel like this is a lot easier to understand when we're actually going back and forth and talking about it, but I'm going to do my best. Okay, so this is our normal heart for comparison. So defect number 1 is, this is our right ventricle, and this is where blood would go normally to our pulmonary circulation, right? This goes to our lungs. So here we have this narrowing. Do you see how big this leaflet is and this vessel is? So here we have what's called pulmonic stenosis or pulmonary stenosis. So this is number 1. I'm going to try to keep it, let's put it over here. So pulmonary stenosis, number 1. So you have this narrowed vessel slash valve where blood should be able to flow from the right ventricle into the pulmonary circulation. Number 2, you have a VSD, which is an opening between your right and left ventricle. So it's usually right here. So that is going to be number 2. So ventricular septal defect, VSD. So number 3 is called an overriding aorta. So you have this aorta here. See how it's purple? Why is it purple? You have this mixing of deoxygenated and oxygenated blood, because you have this super narrowed pulmonary vessel here. So you have this massive aorta right here, and it's overriding both the left ventricle and the right ventricle. So you have number 3, which is an overriding aorta. And because of all of this, the heart has to work really, really, really hard. So that's where you get this right here. See this big chunky muscle here? So this is number 4. And this is right ventricular hypertrophy. So 4 defects: pulmonary stenosis, pulmonic stenosis. You have this narrowed stenosed vessel here or valve. So blood is having a very difficult time getting into the pulmonary circulation. You have a VSD or an opening between the right and left ventricle. So you have mixing of blood here. Because of this very narrowed vessel, you have an overriding aorta. So the aorta is actually, instead of just being over the left ventricle, you have it over both the right ventricle and the left ventricle. So that's why you have this purple blood or mixed blood. And then your heart has to work hard, right? So you end up developing this right ventricular hypertrophy or RVH. So that is the fourth defect. Let's see. How does the nurse explain this cardiac defect to the father, specifically the consequences pertaining to the baby's circulation? So you essentially will have this mixing of blood. So I think the first thing that you have to understand in order to answer this question is that there is a degree, if you look at like a scale of how severe this condition will be depending on the baby, and it varies. So some babies have very, very mild forms of this disease, and some have very, very severe forms of this disease. So I guess my first question for you to think about is, which of these four defects do you think dictates how sick or how severe this patient will experience tetralogy of Fallot? So the answer to that question is number one, your pulmonic stenosis. So if you have only a very mild stenosis of this, like maybe it looks like this, it's not super severe, then you are still able to, despite everything else, get some degree of adequate blood flow from the right ventricle into your lungs. And you won't have as much of this hypertrophy because your ventricle won't have to work quite as hard. But let's say you have a very, very, very severe form. So you have a very narrowed, or a very, very severe form of this disease is actually an atretic vessel or a pulmonary atresia. So it's completely closed. So those are going to be your very, very sick babies, because no matter how hard you try, you're not getting any blood through here. So you have to have another opening that allows blood to mix. So how bad your pulmonary stenosis is dictates how sick clinically the patient will be. That being said, what are consequences for this baby's circulation? So when this baby is calm and healthy, not sick, not dehydrated, this baby, if this is not super, super severe, this pulmonary stenosis, this baby will likely be okay most of the time. But what do you think happens when the baby's metabolic or oxygen demand starts to increase and the baby's not able to get more flow through this pulmonary, the stenosed pulmonary artery and into the pulmonary vasculature? What do you think will happen? So the baby's going to get angry, upset, crying, they're sick, they're dehydrated, and guess what's going to happen? The aorta is going to steal more of that circulation. So the blood that's actually getting into the pulmonary vasculature is less, and that is where you see TET spells. And I think, if I'm not mistaken, I have to scroll down in our packet, but yep, we will get to what a TET spell is later. I've kind of already described it to you. But that is going to affect the baby's ability to oxygenate their blood effectively, and it's going to make them blue, and it's going to be scary for the parents. So those are kind of the consequences for circulation. And then, of course, you have this overworked heart, so you're going to have an element of heart failure there. Depending on how sick this baby is. Again, some babies have very, very mild forms and they can go home with this disease, and you just have to teach the parents how to manage it. I know just today, actually, one of my good friends and partners that I work with, she's one of our nurse practitioners, had to take a very, very, very sick tetralogy of Fallot baby down to Seattle for surgery because despite all of our efforts, this baby was having significant TET spells where our oxygen saturations were in the 20s. The baby wasn't doing well, wasn't coming out of them. Um, so again, it varies depending on how sick the baby is and how severe these different defects are. Our next question, number 3, what causes the cardiac silhouette to have a boot-shaped appearance on the chest x-ray? So I pasted in a sample chest x-ray for you, and typically the shape of the heart is more kind of like that. Well, that was probably a bad example. Hold on, let me try again. It's usually more like something like that. But in this scenario, you have this boot, and what causes that boot shape is this right here. What do you think causes this? So it's this right ventricular hypertrophy. So it's that overworked muscle, makes the heart bigger, and that's what makes this have that boot-shaped appearance. If we think back to the very, very first question that we answered when we started this recording on the persistent PDA patient and the echocardiogram. So just something to keep in mind, x-rays do give you some information. So if I had this baby with respiratory distress or what seems like respiratory distress and they're cyanotic and I don't know what's going on, and I get an x-ray and I look at it and I see this boot shape, obviously it doesn't tell me that the baby has tetralogy of Fallot. The only way to diagnose that is with an echocardiogram. But it does give you a hint with this abnormal cardiac silhouette that there is some problem. So it's still a helpful tool, but it doesn't diagnose this disease. Our next question, Jack's mother arrives and asks how this condition will be treated. How does the nurse respond? So in this scenario, reading the case study, this is a pretty severe case. So this baby, the way that you would respond is that your baby will need surgery. And it's usually multiple different procedures that need to be performed depending on the severity, which will be determined by the surgeon. So the only thing I want you to take away from that question number 4 is you would respond by saying the condition will be treated with surgery. For number 5, what is a TET spell and what causes it? So we kind of touched on that already. I think we pretty much answered that question. You have some situation where a baby has an increased metabolic demand and increased oxygen demand. The baby starts to cry and get upset. You already have this stenosed pulmonary artery and pulmonary vessel here. So this is going to be even more, or it will be even more difficult for blood to get into your pulmonary vasculature and oxygenate to be able to carry to your body. So the aorta is going to actually steal a lot of that blood flow. You're going to have this shunting. A lot of that blood is going to go into the aorta. So you're not having as much oxygenated blood that circulates, which is going to make the baby blue. And your main things that you want to do are to calm the baby down and keep scrolling down my page. Sorry, I didn't have all the questions on there. If this is a baby, you're going to do something to try to help force blood through that vessel. So for a baby, you would do knees to chest. And then if it's a child, you'll actually see children with this disease kind of do it instinctively. So you'll see these kids playing on the playground, having fun. They get overexerted and you'll just see them randomly squat down. And that squatting down helps to kind of force blood into that pulmonary vessel and help to get that oxygenated and circulated throughout the body. So it's super, super, super important when you're doing discharge teaching for parents of these babies and children to talk about, especially in babies, the knee to chest, the importance of calming them down and consoling them, because obviously if you let them allow to, just keep screaming and be angry, they'll get to a point where they're not getting hardly any oxygen that can circulate, and eventually they'll pass out. So it's super important to teach consoling techniques and the knee to chest. And then with children, to talk about the squatting and why they do it. Number 6, Jack is too small to undergo surgery. What important education does the nurse provide to the parents at the time of discharge? So we already talked about it. I got ahead of myself. I'm sorry. Knee to chest, consoling measures, the importance of staying healthy. So you want these kids to, you know, obviously you can't prevent all illness exposures, but these are kids that you really want to prevent from getting sick or dehydrated because, again, all of those things increase your metabolic demand, oxygen demand, staying up to date on immunizations, all of that stuff. So, super important education. Another thing to mention, depending on the severity of this illness and how things are shunting when they look at the echocardiogram, these kids also might need their PDA in order to survive. So it just really depends on how complex this congenital heart defect is and whether or not the PDA will be helpful. I know that the patient who went to Seattle earlier today, we did have to start prostaglandin the night prior because that baby was just not doing well. So just something to keep in mind. And I think I'm just going to keep talking because I don't think we need any more diagrams or pictures. So for case study number 7, James is a 4-year-old who presents to the clinic with a fever of 104.8 degrees Fahrenheit, red lips, and a strawberry tongue. The provider orders a rapid strep test, which is negative. Based on these findings, what condition does the nurse suspect? So the answer to that is Kawasaki. What causes this condition to occur? So we don't really know. We think it may be autoimmune. Um, no one's really sure why it happens. So some people think that Kawasaki could be linked to a previous illness, like maybe a viral illness or some type of environmental exposure, but nobody really knows what causes your body to react in the way it does when you develop Kawasaki. And this is typically seen in very young children, 5 or younger. And our next question, what does the nurse tell the mother when she asks how James will be treated? So, what happens in Kawasaki is it is an inflammatory disease that typically affects your coronary arteries, and it can cause weakening of those arteries. And so, a primary treatment for Kawasaki is high dose aspirin, and that can help prevent the development of an aneurysm because of the weakened walls of your arteries. So that is the big one, high dose aspirin. And it's important to remember that because typically in children, and I know Dr. Marnell has probably already reiterated this to you a number of times, we don't use aspirin as a um, antipyretic or as a pain medication in children because of the risk of other issues. And so we do use it in Kawasaki because of this very specific reason. It's to prevent aneurysms and to prevent weakening or further weakening of the walls of the coronary arteries. So, something important to remember. Another thing that they can utilize to treat this is something called intravenous immunoglobulin or IVIG. And what that does is it's an infusion that contains a pool of donor antibodies, and it helps to just mediate the way that your body responds to um, varying types of inflammation. And it kind of tells your body in autoimmune situations just to kind of calm down, and um, it acts kind of as a way to dilute the amount of antibodies circulating in your own blood. So it just really helps to mediate that response. The thing with IVIG is you can only give it really a couple of times, and it's not a long term solution. Um, it's very expensive, and in many instances, it doesn't work or doesn't have a very effective response. And then we have some NCLEX review questions, and then I will go over our my case presentation, and then we'll be done. So our first NCLEX review, we have Liam, who is a 10-year-old presenting to the clinic with red swollen joints. He is tachycardic and has muffled heart sounds. A chest radiograph is performed, which reveals cardiomegaly. An ECG is performed, which reveals a long PR interval. The provider suspects rheumatic fever and orders an anti-streptolysin or ASO titer. The nurse understands that the provider suspects this due to which factor in the child's medical history. So A is exposure to HSV 1 month ago. That is incorrect because rheumatic fever is typically related to something else, not viral. So HSV is a virus. That's incorrect. C, hepatitis B carrier status due to exposure at birth. Again, hepatitis B is a virus. C would be incorrect. And then D, gastroenteritis 1 week ago. Gastroenteritis is also viral and would not cause rheumatic fever. So the correct answer is B, untreated pharyngitis 2 weeks ago. The child likely had strep, group A strep, and if group A strep goes untreated, it can seed in other parts of your body, such as in your heart, which is not good. And so likely if that anti-streptolysin titer comes back and shows high levels, it can be that that was the problem. So that would confirm it. Question 2, L is a 14-year-old diagnosed with hyperlipidemia and hypercholesterolemia. The nurse provides the following education to the child regarding the treatment plan. So the correct answers are A, avoiding simple sugars such as white bread, pasta, cookies, and cakes. Let's see. B, cook meals with olive oil. That would be a correct one. E, keep appointments for routine lab draws as recommended by the provider. And F, participate in regular exercise. So B is incorrect because decreasing dietary fish intake would not help the problem. You want dietary fish intake because those have the good omega-3s and the good fats. And the same thing with D, avoiding avocados and nuts. Avocados and nuts have the good fats that you want to have in your body. So B and D should not have been circled. The correct answers are A, C, E, and F. And I'm going to pause one more time while I pull up my case presentation, and then we will be finished. Okay, so I am going to share my presentation with all of you. And hopefully this will kind of just tie everything together and reiterate to you just why we are so passionate about teaching you this information, and I don't know, maybe one day you will kind of be in a similar situation and think back on all of this information you've been taught and it will help you. So this was a transport case review for a couple summers ago that I did. So I was initially notified that this was a 10-day-old female. She had presented to the emergency department in Soldotna Central Peninsula Hospital. There was a Life Med crew already at the bedside. It was a rotor crew. The baby was hypothermic, so she was 93 degrees Fahrenheit, and that was a rectal temperature. The reason that the rotor crew didn't take her is that she was, one, very critically ill, and they felt that because she was so cold, they wanted the isolette or the transport incubator. So they requested that Life Med Anchorage come and get the patient, and they requested a nurse practitioner from the NICU to accompany the baby with the equipment. And the infant was to be admitted to the Providence PICU. So this is the notification that I got when I first got the call. So at that point, I went ahead and called a medical consult with the accepting physician. So that was the PICU intensivist. She had just spoken with the ED physician out in Soldotna and gotten the following information. So 10-day-old female born at term, came into the ED by the parents because of mild respiratory distress and hypothermia. He told the intensivist that the patient was on a quote unquote whiff of oxygen. He was concerned for sepsis. They performed a blood culture and CBC. The results were pending. They started antibiotics, including ampicillin, gentamicin, and cefotaxime. They gave her multiple normal saline boluses. They were attempting an LP. They had already had one failed attempt, and more attempts were in progress. Um, Per the ED physician, I can't see the bottom of my screen, sorry. The baby was quote unquote doing much better, and the only anticipated need that the intensivist had for me based on what report she got was that the baby might need to go on some high flow nasal cannula. So this was the information I got en route to the hangar. So we arrive and get the following maternal history and delivery information. So this was a scheduled repeat C-section, routine resuscitation at birth. They didn't know the specific APGAR scores, but they were good. The mom was GBS positive and was treated with prophylactic C-section antibiotics. That's typically your one dose of Ancef. And otherwise, the baby had a normal course and was discharged home at 48 hours. So this was after delivery, this is what happened. So we get to the bedside. We get report from the physician, the RN, and the life med rotor crew. My examination of the baby, just a brief look, was the baby was non-dysmorphic, so normal appearing in terms of like what parts are there, normal appearing head, all the body parts are there. Female infant on a radiant warmer. She had moderate to severe respiratory distress. She was on respiratory support, high flow nasal cannula, 7 liters per minute with 100% supplemental oxygen. So, just to stop for one moment, that is not considered a whiff. A whiff of oxygen is like maybe a liter, maybe half a liter, definitely not 7 liters. 7 liters is the highest that we typically go for a neonate. For IV access, the baby had a saline lock in the left arm. And then I asked the ED physician about her chest x-ray, and he just told me, oh, it's normal. So I did a complete physical exam, and these were just the things that were abnormal. So she was pale, had low tone and low responsiveness, breathing fast, grunting, moderate to severe retraction, so use of those accessory muscles, coarse breath sounds throughout. She had a rapid heart rate, a harsh murmur, audible throughout the chest. She was her precordium, so that means that you can see the heart beating through her chest was hyperactive. So that means it was there. Typically, you shouldn't see the heart beating through a patient's chest. Weak brachial pulses, absent femoral pulses, delayed capillary refill. Her liver border was palpable all the way down to where her belly button was. She had decreased bowel sounds, and she was cool to the touch. So to this point, all of the people that I had encountered felt that this was infection. So this is a normal chest x-ray. So you can see the heart normal appearing. Usually it's about 50% of the entire length. So from rib cage, one end to the other, the largest part of the heart here would be about 50% of that total. So this is a normal one. This is not this patient. So this is this patient's x-ray. It's not the best picture because it was taken with my phone, but this is absolutely massive. Huge heart, overworked. Lots of fluffy stuff here, lots of excess fluid, likely because we have pulmonary overcirculation and some degree of heart failure. And the other thing to look at is this baby's on 7 liters. If you look at the lungs, you can see the lung tissue kind of bulging between the ribs. So that's a lot of flow for this baby. So this was our blood gas. We had a pH of 6.79, CO2 of 19, O2 of 14, bicarb of 6, and a base deficit of minus 26. So this is severe, severe, severe metabolic acidosis. So this is how we manage the baby. Something I didn't. This is what I presented to my nurse practitioner team. So they kind of knew a lot of the story, but I called medical control and I just said, this definitely does not look like infection. This looks like a cardiac patient. If you just look at the story, a baby coming in at 8 days old who was previously fine with all of these findings, this is very clearly not and does not appear to be infection. So we intubated the patient, put her on the ventilator, started an infusion of prostaglandin, placed 2 more IVs, placed an arterial line, gave more saline boluses, and gave a bicarb bolus. And disposition. So arrived at Providence. The baby was super, super sick. Emergent echo, like the cardiologist was at the bedside, and they said that she had a severe coarctation of her aorta. The entire aortic arch was about a third of the size of the pulmonary artery. So she had severe impaired blood flow and oxygenation to her body and to her organs. We placed a PICC line, and then in critical condition, she was transported to the Seattle Children's Cardiac ICU. So I can't remember if I said this in the beginning, but the biggest takeaway and why we really go into depth teaching you about cardiac defects is that I know many of you probably aren't interested in working in peds and probably look at these case studies and think like, hey, I'm never going to use this. This is pointless. This is a waste of time. But the truth is, most of these babies that are picked up in the ED, and many of them die because it goes unrecognized that this could be anything but infection. And so I think it's just important to keep in the back of your mind that sometimes, especially in babies in that first 2 weeks of life that come in, they're 10 days old, 7 days old up until 2 weeks old, 3 weeks old, and they are all of a sudden sick, having respiratory issues, are cold, are not feeding well. It could certainly be cardiac. And so in the instances where this goes unrecognized, by the time they figure out, they've done all of these other interventions, the baby isn't getting better. Ultimately, the baby becomes so acidotic that they die. It's just something to keep in the back of your mind. And we try as best as we can to increase awareness because we know that, we unfortunately in Alaska cannot treat many of these conditions. These are kids that need to safely be transported to the lower 48. And so the longer that these conditions go unrecognized, the more likely it's going to be a poor outcome for the patient and their family. So, thank you so much for taking the time to listen to this lecture and to do the work. I know that it is a lot. I know that it's a lot to do online, especially without having the interaction one-on-one or in a class setting. But I really do encourage you to come to my office hours if you're confused, or to schedule a time to meet with me. I'm more than happy to help you. I hope that this was helpful. I hope that you learned something from this recording. And again, please reach out if you are confused. I will post the link to my office hours and my contact information within your Blackboard announcements. So with that, I hope you guys have a great rest of your week. And please, again, reach out if you need any assistance.